Okay, so first of all, I just want to thank everybody for taking the time this afternoon to join this call. We're really excited about the progress about PDOPPS, and first of all, I just want to thank the coordinating staff at Arbor Research, actually, that have been doing such a fantastic job in organizing the study, and want to thank them for putting together today's teleconference. And of course, I think a warm thank you to all of you participating medical directors, nurses, and administrators, and everybody who is making this research possible. And it's really a great endeavor, and it's truly not without the collaboration across the country. So just a warm thank you to everybody and for your time today. So I just wanted to point out another thank you to our country investigational team. What's really unique about PDOPPS is that we've been able to get funding in many countries from local peer-reviewed funding as well as governmental funding and industry funding, and that's been a very exciting collaboration. And I just want to thank these country investigational teams in Australia, Canada, Japan, the UK, and the US, as well as an exciting development in Thailand and New Zealand we'll be talking about. And I'll be sharing with you some developments there. And just thank you for your efforts and support. The other group of people with whom collaboration has been incredibly successful is the ISPD. We started off with a vision to really better understand the determinants of technique survival on TB, and really looked to the ISPD to help pull together some key opinion leaders and experts to help us develop our research hypotheses within PDOPPS. And to that end, we've centered the work groups, which have worked very carefully on reviewing and developing the questionnaire and content, as well as developing the study hypotheses. And we have several work groups to thank. Those are the Clinical Application of TB Therapy work group, led by Dr. Malhotra, really looking at how we use and select patient candidates for TB across the world. Looking at TB access and function, led by Martin Wilkie, looking at dialysis prescription and fluid management, led by Angela Wang and Simon Davies, looking at patient training and education and its determinants of patient and technique survival, led by Ana Figueiredo from Brazil. And then lastly, the really important psychosocial aspects of delivering TB, namely patient support, led by Fred Finkelstein. So I'd like to thank all the work group members for their efforts. So what we're going to do today is really provide an introduction and provide some objectives. We'll talk about how the study is progressing worldwide beyond the U.S., and we'll also talk about some U.S. Study updates as well as some preliminary data. I'll talk about the formation of the U.S. Advisory Group and its mandate, and then we'll talk a little bit about research and publication opportunities, and lastly, we'll talk about the year ahead and what some of the future goals of the study are. So let's provide a worldwide study update. The study has been launched successfully in several countries, and we're really pleased to have ongoing data collection in Canada, the U.S., the UK has recently started, as well as Japan and Australia, which both have come online, all recruiting facilities and patients. Thailand is the map or the flag you may not be as familiar with, and they are hopefully going to be joining the study in the future. We've had some very positive preliminary discussion with Thailand, and that will be very interesting because it will be one of the first developing countries to join PDOPPS, as well as a country that has a TB-first policy. So this is where we hope to be in 2016. Next slide. In terms of Canada and country-specific updates in Canada, I'm the principal investigator for PDOPPS Canada, and we've recruited our target of 20 sites. And we have collaborative funding through the Canadian Institute of Health Research. In Japan, the investigator is Dr. Hideki Kawanishi, and it's been begun at 25 sites, and we have a target of 33. And that's funded through the Japanese Society for Peritoneal Dialysis. In Australia, under the leadership of David Johnson, we're very excited to report that 13 sites have randomized out of the target of 20. And that's also similarly funded through a government body called the National Health and Medical Research Council. Both of those, the CIHR and NHMRC, are very similar to the NIH you might be more familiar with in the U.S. And in the UK, Dr. Davies and Dr. Wilkie are the principal investigators. So far, 20 sites have been targeted and is funded through the NHS Research Portfolio. And And interestingly, there's also a subset that I'll talk about that was funded by the NHR in the UK, which again is similar to the NIH. And then lastly, New Zealand will have 2 sites that are participating and hopefully will be on shortly. And that's under the leadership of Dr. Mark Marshall, with a goal similar to the UK to submit for a governmental funding for an ancillary study. This is the progress in terms of facility startups. So in the United States, we have a target of 80 facilities. So far, 75 have agreed, and 69 have started the study. In Canada, all 20. Japan, 33 are targeted. 24 have started up activities. Australia, 12 out of 20. New Zealand, 2, and that's our target, but none have started up yet. And in the UK, we have 1 facility that's gone online with a target of 20. So we have fairly good agreement for participation. Thailand is a goal for the future, which we'll talk about. So I think we're meeting our targets very nicely in terms of the progress on the study and where we're supposed to be, with 74% of facilities targeted having started the study and 85% having agreed to participate in the study. Next. And in terms of the enrollment in the U.S., the census, remember, is the big denominator upon which all patients in the study are selected. So it's the roster of patients, all participating facilities. So in the U.S. in particular, we have 3,859 census patients. That represents patients at all facilities. And what we're hoping to do is have all those selected patients participate. And we've selected 2,026 patients randomly. And of those patients, 1,708 have consented. So that's been an 84% consent rate. And you can see that the consent rate in the U.S. is fairly comparable to what we're seeing in other countries. And you can see that, of course, as the study starts up, more patients will be offered participation, and we will hopefully obtain higher consent rates in some of the countries like Australia and the UK that might be earlier ahead in the trajectory. Next slide. In terms of some U.S. study updates and some preliminary data, as you know, in the U.S., we're targeting both LDO and non-LDO facilities, and we've targeted 40 FMC facilities and 40 non-LDO. And of these, 68 sites have randomized, so that's very exciting. There's also been a patient questionnaire that was successfully launched and completed, an electronic patient questionnaire as part of the sub-study. So far, 614 were completed and 949 were approached through this patient questionnaire. So that's really outstanding. And then lastly, which I think is very exciting, is we've had some very positive discussions with DaVita to potentially join in the PDOPPS US study. And we'll keep you posted about the developments in that regard. This is the distribution of facility sizes for DOPPS. So on the x-axis, you can see the number of census patients in each facility. So there's facilities that have over 100 patients, 71 to 100 patients, 51 to 70, 30 to 50, and less than 30. And what I just wanted to point your attention to in the blue is how the U.S. fares relative to the rest of the PDOPPS facilities. And I think similar to Japan, what we're seeing is a larger proportion of smaller facilities compared to other countries where there may be greater aggregation of patients within larger facilities. So overall, similar to Japan in the sense that there's a higher proportion of relatively smaller census facilities participating in the study. And that's very well described in terms of the landscape of U.S. practice of PD in terms of smaller facilities but more greater frequency of facilities. Next slide. And this is the initial selected patient characteristics. So this is data from 24 participating facilities and 582 selected patients in the U.S. And I just wanted to point out we have some preliminary demographic and comorbidity information. And interestingly, what we're seeing as a trend is we're seeing a much higher proportion of patients in the U.S. that are female, so 43% relative to other countries, and generally a tendency to a younger peritoneal dialysis population with an average age of 57, or median age of 57.7 years. The other thing, if you'll notice, is just looking at comorbidities, the prevalence of diabetes in our cohort is around 30% as a cause of end-stage renal disease, 44% in the U.S. as a comorbidity. And that pretty much puts it slightly higher than Australia, but slightly lower than countries like Canada and Japan. And it is interesting because does that reflect some differences in what patients and what patient populations are selected for PD in the U.S. relative to other countries? And we're going to be exploring those hypotheses within the study. Next slide. The other thing that you will note here is that this is some other selected characteristics. Again, 22% of patients in the U.S. have some college or university education, which seems to be higher than in some of the other countries participating. And looking at some of the laboratory parameters, you can see similar to the trends in the hemodialysis study, which you can see at DOPPS.org and follow on the DOPPS practice monitor, we're seeing much higher ferritin levels in the United States in terms of trends. And in the peritoneal dialysis population, you can see the ferritin is highest in the United States relative to other countries. The serum albumin is actually highest, which again might speak to the overall comorbid burden of the U.S. PD population relative to other countries. And again, iron saturation is higher at 32%. Next slide. And that might be one of the reasons might be in its use of IV iron in the U.S. population, which is at 30% relative to IV iron use in other participating countries, which is high, between 3.7 and 6.1%. So significantly higher IV iron use in the U.S., which might be driving the differences in iron indices. Higher oral vitamin D use at 69.1%, and significantly higher phosphate binder use at 76% relative to other countries. So some very interesting initial baseline data of our selected patients in the U.S., and already it's very exciting to see some emerging differences exist between the U.S. PD population and the rest of the world. Next slide. Just some PD-specific practices. This is the percent of patients being treated with APD and CAPD. And as you can see, the U.S. has the highest population, or highest percentage, rather, of patients being treated with APD, or automated PD, relative to continuous ambulatory PD at 81%, followed by Canada, and then Australia and Japan. And then next slide. Among those APD patients, this is examining whether or not there's a daytime exchange or a so-called wet day. And what you can see here is in the U.S., there's a fairly similar proportion across the countries, with roughly around 40 to 50% of APD patients using a wet day over the course of their PD therapy. Now remember, this is both prevalent and incident patients, and in as much as we will begin to recruit a larger proportion of incident patients, we'll also have an opportunity to look at this in terms of the incident PD prescription. In other words, the first PD prescription a patient gets. So this is just among prevalent patients, many of whom may have been on PD for quite some time. Next slide. In terms of other practices related to automated PD, this is looking at the number of cycles or the number of overnight exchanges in APD patients, ranging from less than 3 in the orange, 4 in the dark blue, 5 in the green, and greater than or equal to 6 in the lighter blue. And again, what you can see is when you look at patients using 5 or greater than 6 or equal to 6 exchanges, that proportion seems to be quite high in Australia, and the U.S. is roughly around 41% using 5 or more exchanges. So fairly comparable to Canada, slightly less than in Australia, and significantly lower in Japan, where the majority of patients are using less than 3 or 4 exchanges overnight. Next slide. In terms of CAPD, just along the theme of dose of dialysis, this is, orange is less than 3 CAPD exchanges or equal to 3. The dark blue is 4 CAPD exchanges. And the green is greater than or equal to 5 CAPD exchanges. Again, you can see on average, 4 CAPD exchanges seems to be the most common prescription across countries, with a slightly higher proportion of U.S. patients at 10% using 5 or more exchanges. Next slide. In terms of how that reflects total delivered dialysis dose, interestingly, if you look at the higher end of dialysis dose in the green at greater than or equal to 2, 61% of U.S. patients are being treated at a greater than or equal to 2 KT over V target. are sort of reaching a total KTOV of greater than or equal to 2, and that seems to be highest among the participating DOPPS countries. In terms of KTOVs of less than 1.7 per week, total KTOVs, the country with the greatest proportion of such patients is 50% in Japan. So there's definitely a trend of higher total KTOVs in the U.S. relative to other countries. And I think that will be very interesting and might reflect some of the practices with regards to achieving the KTOV and the implications of achieving a total KTOV of 1.7 or more in one country versus another. And again, hopefully what we'll be able to do with this data is examine that impact on patient outcomes as more longitudinal data becomes available. Next slide. Lastly, looking at some other parameters, residual kidney function as measured by 24-hour urine volume. Again, looking at the distribution, this is in the orange, less than half a liter, the dark blue, half a liter to 1 liter, the green, 1 to 1.5 liters, and the light blue, over 1.5 liters. What we can see here is Australia seems to have patients with a much higher proportion of the higher spectrum of residual kidney function. United States, Canada seem to be fairly comparable with some subtle differences. And if you look at Japan, also fairly similar and not too drastic differences. But certainly there's some differences between Australia and the rest of the PDOPPS countries. Next slide. One really exciting opportunity, which I think we should really highlight in this presentation, is that in addition to collecting lab data and patient comorbidity data and outcomes, the patients themselves are completing a questionnaire, the so-called patient questionnaire. Part of the component in the U.S. will involve not only a paper patient questionnaire, but an electronic one. And this really offers us an opportunity to get some really important patient-reported outcomes. One of the patient-reported outcomes that's routinely collected is the KD QOL, looking at quality of life. And quality of life can be broken up into the physical component scores and the mental component scores. And this is just looking at the physical component scores in Canada, Japan, and the United States. The blue is comparisons across PD populations. The orange is what traditionally our quality of life measures have been in the hemodialysis population. And what you can see here, this is 2012 hemodialysis data, looking against 2014 PDOPPS data. And interesting, what you can see overall is that within a country, there's fairly similar congruency between the physical component scores in Canada, Japan, and the United States, so between PD and HD patients. If anything, Canada has similar scores. Japan, slightly lower scores for hemodialysis, so I'm not sure the significance of that. And in the U.S., there may be a slightly larger gap, but again, whether this is statistically significant is not known. These are some preliminary data, and we'll be able to make much better estimates once we have the entire PDOPPS cohort including patient questionnaires used. The other important inference here is to compare physical component scores between countries. And what you can see here is the score seems to be highest in Japan and fairly comparable between Canada and the United States. And the reason some of the other countries are not included here is we do not have enough patient questionnaires that we've received just yet to include those countries. So next slide. That's a little bit different than the mental component score, which you can see is fairly comparable between PD and HD populations within each PDOPPS country, and also is similar between countries in both PD and hemodialysis populations. So that physical component score difference we saw in Japan doesn't seem to be here relative to the mental component score. Next slide. So one of the things that I wanted to highlight is we have seen and understand that U.S. peritoneal dialysis practice is very different than in the rest of the world. And what's really important is to get the feedback on what are some of the U.S. specific issues and how can we make the study that much more meaningful to U.S. peritoneal dialysis practice. So we've established the U.S. advisory panel, and here's a picture of our first meeting at ASN 2014. Next slide. And this is the panel membership of the U.S. advisory panel. Arbor representation by Francesca Tentori as the lead, and Raj Malhotra representing the ISPD-NAC study, as the ISPD-NAC organization, as well as the U.S. Advisory Group co-chair. Next slide. And the overall arching goal of the U.S. Advisory Group is to review the study progress and priorities, to ensure that we're looking at the views of all stakeholder groups in the U.S. PD community, they're all represented as advisory group members, and really ensure that the PDOPPS goals and accomplishments are communicated effectively to the U.S. And largely to the dialysis community in the U.S. This is also the conduit where, if you are interested in having an ancillary study move forward in PDOPPS, where reviews or requests for ancillary studies could be put forth, specifically in the U.S., and I'll highlight some ancillary studies in the upcoming slides. And really, we want PDOPPS to be a much more comprehensive resource to the global PD community. And certainly we want to encourage the use of PDOPPS and data holdings as a resource for junior investigators to help develop and launch their careers, particularly relating to PD research. Next slide. So in terms of the research and publication opportunities, next slide, there is an opportunity for investigators to propose ancillary studies, and as mentioned, we have a very robust infrastructure and forum in place to promote collaborative international clinical research. And these ancillary studies can really also be used as an entry into PDOPPS, as was successful in the UK, where funding of an ancillary study really allowed the overall study to take place in the UK. And specific funding mechanisms do exist through the NIH as an ancillary study, particularly for young investigators. A K award or a career development award may be a very attractive avenue to look at in terms of proposing a funding mechanism for an ancillary study. Next slide. Just to give you an update on our existing publications, the study rationale, design, and methods paper was recently accepted in Peritoneal Dialysis International and should appear in electronic print very shortly. And in addition, we have a publications policy statement, and it's been developed. And this really just will track how we propose and move forward with various proposals for publications based on PDOPPS data. And that's available by emailing pdops@arborresearch.org if you're interested. Next slide. In terms of some of the ancillary studies, these are the three large funded ancillary studies in PDOPPS, the first of which has been funded by the Patient-Centered Outcomes Research Institute in the U.S., the PCORI body, and this is the EPOC RRT study. And the PI of this study is Francesca Tentori, which is looking at the patient experience of choosing one modality versus another. And it is a mixed method study with qualitative and survey data looking at peritoneal and hemodialysis populations that will really help us understand why some patients choose one therapy over another. And that study is underway, and I'm sure we'll hear in the future further progress and developments on that study as it comes forward, and it's a very exciting study. The other study is the UK CAF study. What this study really is looking at is before patients actually enter into PDOPPS, they have to have a PD catheter inserted, as you all know, and have to actually have a functioning PD catheter. And that window is not captured with the same detail in PDOPPS, where patients really start at time zero when they're presenting for training. But to better understand PD access dysfunction, the UK catheter study will enroll patients earlier in the PD trajectory when they're going for their PD access insertion, and will continue to follow a proportion of those patients into PDOPPS to look at more long-term outcomes. So we're really excited to get some insights into early PD access dysfunction from our colleagues in the UK, and this is a UK-wide study. The last study, which is also very exciting, is leveraging the fact that we're going to be having one of the largest international cohorts of PD patients to be studied. And this is under the leadership of Raj Malhotra and funded by the NIH. The BioPD study will sample peritoneal effluent and blood samples, and will look longitudinally at how those samples predict baseline peritoneal membrane function and how those samples predict longitudinal membrane function, and those samples will be assayed for genetic determinants. So hopefully this study will really help us answer biologically from a genetic perspective, is there a basis for understanding some of the changes and differences in peritoneal membrane function between and across populations of patients. Next slide. So just as an aside, if you're interested in participating in the BioPD study, please let us know as well, and we'll be happy to feed you through the right channels if you haven't been approached already. Next slide. So what's ahead? What does the future of PDOPPS 2016 look like? We're really hopeful that we'll expand to Thailand in 2016, and as mentioned, we've had some very exciting discussions with leadership in Thailand. We are currently looking at manuscript proposals that are in development, really trying to distill some of this initial cross-sectional data we're receiving. Ancillary studies are in development, and PDOPPS data is being presented all across the world at several forums, including EuroPD, the European PD meeting, the American Society of Nephrology will have an oral presentation, the Dialysis Conference, and ISPD Melbourne, where we'll have a PDOPPS symposium. Next slide. So just to summarize, 7 countries have started data collection. 7 countries will have started data collection by mid-2016. We've launched in nearly 70 sites in the U.S. and hopefully will enroll over 3,000 patients for our target of 80 sites. We want PDOPPS infrastructure to serve as a resource for researchers in clinical PD outcomes, and I hope to achieve that by expanding opportunities for ancillary studies. And with that in mind, I just want to thank everybody for their time this afternoon. And if there's any questions or comments from today's presentation, please don't hesitate to email us, and the email address is here on the screen at pdops@arborresearch.org. And we always look forward to hearing your feedback and how we can enhance the study. And I'm sure we'd be happy to forward any questions or comments you have to our advisory group in particular in the U.S. And they would be a really appropriate channel for us to steer those comments and questions forward. So thanks so much for your time today, and really appreciate you tuning in.